waiting room.
Excellent. Well, welcome everybody to part 2 of the Division of Cardiology's A New Era for Heart Failure Management into the Calgary Zone. And we've got an exciting evening for you. We've got 4 great speakers. But before I do that, I'd like to just thank our sponsors, AstraZeneca, Bayer, BI Lilly, Novartis, and Servier for sponsoring this evening. And so just a bit of housekeeping, just to remind you to stay mute for the presentations. And if you have any questions, to put them in the chat window, and we'll try to address them after each section ends. And then at the end, we'll have some additional time as well. If you specifically want to do an oral question, so verbal question, please just put in the chat oral question, and then I'll recognize you, and you can come off mute and ask your question at that time. And at the end, we'll have an evaluation. So we'd ask that you fill that out so we can make any changes we want to future offerings. So just to go through the agenda, we're going to start, obviously, I'm doing the opening address right now. And I'm Sandeep Agarwal, I'm Deputy Chief of Cardiology. We're going to then move on to Jonathan Howlett, who's going to talk about our new continuity clinic and introduce one of the new members of that clinic. Nowell Fine is going to talk to us about HFpEF, and there's some new things in HFpEF, so he's going to walk us through some of that. And Dr. Miller, who did a great job of talking about the cluster approach last time, is going to bring it back and both review it and add some practice principles and just make it a little bit more real for everybody so we can figure out how to bring it into our own practice. And then to round it up, we have Dr. Sharma, and Nakul is going to talk about diuretic management in our current environment. And really, for all of us who think we know diuretic management, there are some interesting nuances, and I think everybody's going to learn something from that. And at the end, we'll have a roundtable discussion as well as additional questions, and then close up hopefully before 8:30. We'll see how long we go. It might go earlier, certainly won't go later. So just to introduce our 4 speakers, Dr. Howlett, he did his internal medicine, cardiology, and advanced heart failure at Dalhousie and University of Toronto. And he's actively involved in clinical practice guidelines, generation, and knowledge translation as it relates to heart failure. He chairs both national and international committees in heart failure. He's a co-chair of the annual Canadian Heart Failure Update meeting, which I attended this year and was quite good. And he has over 150 peer review articles. Dr. Nowell Fine did his internal medicine, cardiology, and heart failure, as well as echocardiography at Western and Mayo Clinic. And he has a Master's of Science in Clinical Epidemiology. He's the current director of the Livin Cardiovascular Institute, as well as the Clinical and Research Echo Director. He has a particular interest in infiltrative cardiomyopathies, and now it's a little bit of time now, because last year, or maybe a year and a half ago, that he wrote the guidelines for cardiac amyloidosis for the Canadian Cardiovascular Society, and he has research support from the Heart and Stroke. Dr. Robert Miller did his internal medicine, cardiology, advanced heart failure transplantation, and advanced cardiac imaging at the University of Calgary, Stanford, Cedars-Sinai Medical Center, and he's the medical director of the Nuclear Cardiology and Cardiac CT program, with research interests in advanced cardiac imaging and cardiomyopathy. And finally, Dr. Nakul Sharma did his internal medicine, cardiology, and advanced heart failure and transplantation at the University of Saskatchewan, University of Alberta, and the University of Calgary, has a master's in public health, and he's the Rocky View General Hospital cardiology site lead, as well as the medical director of the Rocky View Heart Function Clinic. He's working towards improving heart failure care in Southern Alberta through the use of order sets, pathways, and knowledge translation. So I will stop there and pass it on to Dr. Howlett for him to present the continuity clinic. Dr. Howlett.
Okay, just getting it sized up properly. Thanks very much, Sandeep. Can you guys hear me?
Yes, we can hear you fine.
Very good. So I always like to show the slides, one of my favorite, not because of the disclosures, but because of the lovely smiles in both individuals on there. And that's kind of what it makes me feel like when I'm watching it. My relationships have not changed. So I'm going to quickly show you some of the things that have been going on in our region and a little bit in the province, and then finish off with a new clinic. Currently, we've been stopping and starting the heart failure pathways, both provincially and in the Calgary zone. In the Calgary zone, it's run through operations. In the rest of the province, it's run through the strategic clinical networks, which is an advisory strategic body to AHS. It doesn't control the space. So the bottom line is that we've had more direct control over the process in the Calgary zone. And in that, we've taken the old heart failure order set that was developed for SCM back in 2009 and repackaged it. It evolved into the provincial order set, and then we modified it, updated it, and then added to it other features. So we have a transition to community care checklist. There's a whole bunch of procedures that each of the floors that commonly see heart failure in each of the 4 hospitals do. There's a QA process actively involved. There's feedback, which I'll show you a little bit about. Patients are risk stratified according to their BNP level. And then there's a discharge management plan that's given to the patient, actually, that says what should we do, some advice, time for their next appointment, and things like this. So when I'm talking about an order set, that's what I'm talking about. That's the SCM order set in Calgary. It's paper order set in the rest of the province. And there's actually an electronic order set for those who have Connect Care too that we won't talk about much. Then there are these are the transition bundles only, and keep an eye on this distinction for later on. And the full bundle is both of them, okay? It's not one or the other. So there's a lot of terminology that can get changed around. We have the order set, we have the transition bundle only, and then we have the full bundle. So we use hospital order sets because they actually have evidence. The evidence is actually a little stronger for reduction of length of stay. But there's also about half of the studies will show a reduced readmission rate. So those are their main hard metrics that we use to measure, but we also have a host of other things like functional class, patient satisfaction, provider satisfaction, and due to time constraints, I'm not going to show you all of that data, but it generally reflects similar trends that we see in these indications. And in fact, CADTH, so those of you who know, CADTH reviews drugs, and they also review other things for reimbursement purposes across the country, like devices. And essentially, they hate everything. But when they reviewed the order sets, they recognize that there's tremendous benefit. So we recognize that as long as you're using evidence-based practices, putting them into an order set, then you can expect to see through this multiple intervention a reduction in adverse outcomes. The 5 key messages that we use to roll this out to other specialists, and to hospitalists, as well as to the community. And one thing we've done very, very well, and Nakul on the call here, he should be congratulated for really helping to integrate this at the Rocky View, especially. We have a lot of linkages with the strategic, with the primary care networks, PCNs. And we've had a very good relationship with them. And these are the 5 very simple messages that we harp on day after day after day, that they need a measurement of ejection fraction. They should get an echo if they don't have one. If it's been a long time or they're newly sick, they should repeat it. They need a specialist to start certain medications, especially ARNIs and SNIs. And co-management and early follow-up are absolutely critical, which we'll get to. So this is a placeholder slide, and it's taken from the evidence that you see below. These are the kinds of interventions that we look at when we've had published randomized data or extensive observational data with many, many, many thousands of patients. And you can see that on the left is the therapy, and then on the right is the number needed to treat to reduce a readmission within the first 60 days when that is indicated. And then sometimes it's followed out to a year. If it says NA, it means the data is not there. So for example, switching an ACE to an ARNI in a randomized trial, for every 13 people you prevented an admission, that's actually cost savings. Now, it actually does have data out to 360 days. I just made the slide a long time ago, and I'm too lazy to update it, and it shows roughly the same number. For those who discharge from hospital in really fast sinus heart rates, adding ivabradine on top of a beta blocker, that's the number to reduce one readmission in 16 days, and so on and so forth. Visit within 30 days versus no visit. You can see how powerful of an intervention. Turns out that if you don't ignore your heart failure patients, they actually do a little bit better. But also, look at this, 7 days versus 30 days. For every 14 people you do that, you actually save. So it's nice to have them within 30 days, but it's even better to have them within 7 days. Finally, if they have both primary and secondary care following them, very powerful intervention indeed. This is versus only one or the other. So it really is a team sport that we're playing here. And familiar people are usually better at taking care of their patients. So this is an example of a dashboard. For those of you who have AHS firewall passwords, you can look at this for the hospital you're in anytime you want. You just need to know where to look. It comes up, it says what your hospital is doing. It's been doing that it's auto-populated. And you can see that there's a pathway developed. This is just a lift from the pathways. It tells you that it's been downloaded many times. We've developed a pathway for family doctors to use. It's very, very popular. And you can see on the right that we've had tremendous amounts of engagement with primary care providers. We did the speaker tour several times, and it's resulted in an improvement in understanding. When we refer people to heart failure clinics, which is what we're trying to get them to do, we have a brand new interactive fillable form on the ARD, so the Alberta Referral Directory. And when you click in that, you will see the referral form. I'll get to that in a minute. When you see this, if you click on the specialist link, and you type in heart failure, this is what you'll get. And you actually can, under the top, you'll see under physician NP resources, up comes this pathway for family doctors to use, for primary care to use. In fact, anybody can use it, and it's based on how we as heart failure specialists would see an outpatient with heart failure. So we think it's very useful, and I can't go through it step by step, but it's pretty much, I think, self-explanatory in that. So these are the interventions that we have. So how are we doing in Calgary? Well, this is the Rocky View Hospital. This is the you can type this up as well as when you're in the AHS firewall, and you can get your hospital numbers. You can see that medication compliance is in one box. 90% of patients had an ejection fraction measure. That's an extremely high number. Usually it's around 60 to 70 at the most. You can see that the order set is used, how many of them had a BNP order, how many of them had appropriate fluid restrictions orders, how many patients were ambulated. Many of you don't know that ambulating patients within 48 hours is actually associated with a shorter length of stay as well as a lower readmission rate. And then patient feedback as well. This is constantly auto updated. And in the middle, you can see the specific interventions that are in addition to use of the order set that are measured to see if these evidence-based interventions are occurring. And so what you'll see here, this is taken from one of the hospitals, and you can see the trend in the upper left. We see that educational provision to patients has really improved significantly. One of them went from 4 to 60%. The medication therapies, you're going to have to take my word for it. There is a statistically significant trend when you add all of those medications together from the beginning to the end, but there's a lot of month-to-month variability. It's one of the lessons of quality control that you don't just take one snapshot. You have to look at trends and you have to see the history behind it. You can see general improvement in ambulation, and then overall heart failure management orders. There's been a general improvement. Some of them are pretty much 100% daily weights. Typically, you'll see well under 80% for that. Our target is to be over 80% for that. The length of stays have come down, and I'll be honest, this is a little bit more than you would expect an improvement, but the lengths of stays during the period that we measured, this is pre-COVID, as you can see. Post-COVID, the numbers are, I think, almost uninterpretable, but we see a general improvement, and we're very pleased with that, and hopefully that will continue into the future. Now, Rob published this earlier, about a year ago now, in the CJCO, and this is the initial association. So this is a retrospective analysis of the impact of the electronic order set in the Calgary region in terms of outcomes. So on the left, you have the overall overall outcomes, and then on the right, it was a carefully propensity matched cohort. And because this is based on over 15,000 patients, we're able to do a very, very tight propensity matched cohort because there was lots of people to choose from. And you can see here that there are fairly dramatic improvements in all of our important metrics. And then when you propensity match them, they're still in, a couple of our really important metrics, especially referral to heart failure clinics. That's the big one. And then some of the activities like EF measurements and daily weights, they have significantly improved as well, even accounting for the order set. And the result has been that there's been a smaller readmission and death rate when you combine it over the first month. That's especially apparent in the first 7 days, and then it persists over the first month. More recently, in our heart failure pathway assessment, we've looked at the pathways units that have implemented the pathways and the units have not implemented. So this is before we were looking at data according to activity. Here we're looking at data according to the units. And as you can see here, that the units that implement the program have much better outcomes than the units that don't. So pretty stark change. Going provincially, and I don't have as much to show you about provincially just because we're in Calgary, so our data is more important than data from elsewhere. But I want to show you that the same trends are apparent. So in the brown boxes, this is the data that was taken before the heart failure pathways were implemented in the hospitals where we measured it. The blue is those sites that did not, those sites or floors or patients that did not get the pathway intervention. And then the green are patients who got the full bundle, not the partial bundle, the full bundle. I'm not going to show you the data on the partial bundle. That's that discharge only bundle that I told you about. So this is the full order set plus transition bundle, as I was telling you before. No improvement if it's just transition bundle. Don't have that data to show you again. But notice here we have statistically significant reductions in 7 and 30-day readmissions. It persists out to 90 days as well. That's statistically significant that you're seeing there. It's a 4%, it's almost a 4% signal, which is huge. There's actually an increase in 30-day revisits, probably because there's a little bit more attention being paid to their care, but it does not come at the price of an increased readmission rate. And look at the percentage follow-ups improve. I mean, that's absolutely massive. Numbers needed to treat here are like 5. And that's true for both GPs. This is seen within a month and specialists seen within 6 weeks. So really quite significant improvements. And as I said, not seen when it's a transition only. So the bottom line is you need to implement all of the program if you're going to get that. So this is a misplaced slide, and it was meant to show you how you get a referral to a heart failure clinic in the Alberta Referral Directory, ARD. So you go here, you click in heart failure, you'll get the heart failure clinics, and the 4 heart failure clinics have the same form. So you just look at, say you want to refer them to Peter Lougheed, you click on there, and it'll be triaged with all the different clinics, so it doesn't really matter which one you click. And then up comes this a disclaimer. So these are the kinds of referral processes that we have, how long you can expect, who can get in, who can't, and then a very intuitive form that explains and takes you through the process. One of the things that you have to do before you get into a heart failure clinic is you need a cardiologist that is willing to take you on within the heart failure clinic. You say, well, why aren't there any internists? Well, we've invited the internists, but they have their own clinics and they're quite busy. So they have, so far, there's only one non-cardiologist following patients in heart failure clinics, and that's a Peter Lougheed clinic. So it's pretty simple to fill out, and we hope that it results in improvement. So one of the things that we've harped on was seeing patients early following transition from hospital. These are the numbers that we have in Alberta. If you look at the bottom, our numbers are well over 70%, where we're very good. Okay, in Alberta, we're very good. We're almost double what many American areas are for seeing within 30 days. Okay, that's pretty good. Most in the US, you'll get around 40 to 45% at the most. But half of the people can't be seen within 7 days, and this jives with questions that we had asked when we did our tour. We asked family doctors in the audience, how many of you could see a patient within 7 days? And basically, out of about 660 docs that attended these, about half of them put their hands up and half of them didn't. So half of the 2,200 people in Calgary every year can't get seen within 7 days, okay, by their primary care. So there's a big hole, and we said we need to help fill that hole. We need to have the safety visit because we know seeing them early will result in better outcomes. It'll have better continuity of care. But we need to make sure they go to their medical home. We need to make sure that they have dual follow-up and all of that together. So we started a new heart failure continuity clinic. And the way it works is it's supposed to be a once or twice clinic where they're seen to make sure they're okay, where there is not obvious follow-up within 7 days either in a heart failure clinic. So here you can see they're discharged from the hospital, either the emerge or from the hospital itself. And are they going to see their family doctor within 7 days? And if the answer is yes, yay, they will go see them. And on the right, you can see if they have a heart failure clinic appointment within 7 days. If the answer is yes, great. We don't need the heart failure continuity clinic for that. Where we want it is if they're not going to have that early follow-up. So right here and right here. Okay. And then once they go to the heart failure continuity clinic, and I didn't put the third level of boxes because it was getting too crowded, but you can see that the options are primary care, ED referral, or CFC referral. So this is the basic pathway that we use. The referral is faxed. Okay, and I'll show you the form. It's processed. You don't see any of that. An appointment's made. You don't see any of that. Patient is approached to come into clinic, and they come in. And then at the clinic, there's a communication made to whoever is going to ultimately follow up this patient, because the continuity clinic does not follow patients longitudinally. And we talk about if the patient's unstable, guess where they go? Back to ER. If they're stable but they need optimization, then we help out with the heart failure clinic referral. We liaise with them. There may be one more visit if we need to clean some things up. And then on the right, if they're well optimized, we say, have a nice day, go see your family doctor, and you need to have a specialist in addition to that. And we don't want to interfere with that. So if they had a cardiologist before, that's the same cardiologist that's going to follow them along, or internist as far as that goes. So we don't take patients away. We try to fill the gap that exists. So this is the clinic. This is the form that we see here. This is fillable. So you pull up the PDF, and I can load that onto the chat. I think I can do that, and if I can't do that, I know Sandeep can. I'll put that into the chat box for people if they want to download it during the other talks. But it's pretty self-explanatory. So it's at the Rehab Center. And who are they? Well, I'd like to introduce May Sumrain. I think, May, you're on the call. She's our NP. She's the star of our show, and she makes it run. And you may want to get, if I know you're home, so maybe you don't want to, but if you're willing, you might put your video on so people can see how nice you are. And when we're doing our Q&A at the end, I think I would like to invite May to come in there in case there's questions, comments that she can help with, because she's really the machinery that makes this whole thing work. And of course, Sandeep and the TC group have been very, very welcoming. There's many great people there. We have cardiology support from all of the heart failure docs and the heart failure leads that are listed there. Special shout out to Omid Kiaminesh, our newest heart failure doc, and to Kristen Lyons, who somehow got deleted from that list. I don't know why, but Kristen Lyons should be there. She should be between the K and the M. Sorry about that. It's not closed to involvement, so if others want to become involved, you're certainly more than welcome. We hope that you got the idea behind this. I'm going to finish with this. This is not from the continuity clinic. This is from people in my own clinic over the past year. And I just took a quick look. I almost killed Netcare getting this information out. And I don't have really good follow-up, and I haven't run all the data in great detail. But I just wanted to give you an idea of what this happened to me and my patients using what Rob's going to talk about later. As you can see, older patients, all EFs under 40, the mean number of changes was 2.2. And as you can see, there's 3 types of patients. Most of them are sort of in between. There's a couple of ideal patients and a lot of frail patients as well. And out of all those titrations and changes that were made, only 4 of them failed. So at the end of the day, I think it's safe. I don't know how many lives it's going to save or not save, but it seems to be well tolerated when you follow it, at least from my very biased mind. So I'd like to leave that with you. So I'm going to hand it back to you, Sandeep. I hope I didn't go over time, and thanks for allowing me to talk today.
Yeah, thanks. I really appreciate you giving everybody an update. Good job. I didn't see any questions in the chat window, so if people do have questions, please put them in. We can always address them at the end. May, I don't know if you want to make any additional comments. I will tell you that with COVID and with some of our nurses having been moved over to ICU caring, so we don't have the as many CFC nurses or cardiac function clinic nurses as we want in all the locations, that it's been great to have May sort of capture some of those patients who might have not been seen. So it's great that we were able to have her help out with those patients. A really good timing to manage these patients. Not seeing any other questions. May, do you have anything else you would like to add? Not hearing anything, I'll move on. So next we have Dr. Fine. So Noel's going to talk to us about heart failure preserved ejection fraction. Noel, take it away.
Okay, thanks, Sandeep, and thanks, Jonathan and May and everyone for joining. Let me just get my presentation up here. Okay, and then I do this, and then I do that. Okay, here we go. So I'm going to talk today about disease I love to hate, which is HFpEF. I love it because I always find it interesting to read about and pontificate on, and I hate it because it is really, really challenging to manage, and it seems to be getting more challenging over time, not less, although hopefully that's going to get better. So we're going to do an update on this. At the end, you may have more questions than you have answers, but hopefully you'll feel updated, hopefully. So we'll see how this goes. So here are my disclosures. I don't have any celebrities or politicians, although next time we do this, I will be sure to include some. So here are our learning objectives. So, we'll start off with kind of a quick update on medical therapies for HFpEF. There's not a lot to talk about, but the big news is what was released at the European Society of Cardiology this summer about Emperor Preserved, and we'll go beyond that. And then we will take a step back and we'll talk about our definitions and categories for heart failure, and with a focus, of course, on HFpEF, and then talk about some trends that are emerging with regards to phenotyping and phenogrouping of HFpEF, and how those might be helpful and how they may not be helpful. Okay. So it's a very sad tale of HFpEF trials and a very, very large graveyard that we've seen accumulate over the years of one negative trial after another. Now, to be fair, some of these trials are not truly HFpEF trials. Some of them are, elderly patients with hypertension trying to improve outcomes, and they get kind of lumped into this. But it's been a sad story, and you'd think even just law of averages would suggest that one of these studies would be positive, but no, it's been a tough nut to crack. And so up until now, what have we had for management of HFpEF? We've had, optimized comorbidities, maybe an ARB, maybe an MRA. We'll talk about why that is in just a sec. But in addition to, maybe not being true HFpEF trials, why have we seen problems? A lot of people attribute this to poor inclusion criteria, and that these patients in many of these trials, even though they were intended to be HFpEF patients, many of them were not HFpEF patients. Some of the inclusion criteria relied maybe too heavily on echo, which sometimes is challenging in patients with HFpEF. So this is where we've been for a while. But in recent years, we've had a few near misses, right? We've had some trials that have come tantalizingly close to giving us therapies, medical therapies to use for HFpEF, and I'll give you 3 of them here. So one of them was Charm Preserve, that looked at candesartan for patients with HFpEF. Another one, of course, is TopCat. Can't forget TopCat, and that was looking at spironolactone. And then most recently was Paragon HF, looking at sacubitril/valsartan in patients with HFpEF. So I'll go through each one of these quickly just to kind of give you a little more perspective on them. So Charm Preserved actually was not new. It's close to 20 years old, and it included patients with an EF of greater than 40%, had kind of what's a standard outcome in HFpEF and heart failure trials, cardiovascular death or heart failure hospitalization. And yeah, there was not a significant difference for the primary outcome. But interestingly, there was a significant difference and significant benefit for candesartan for patients to reduce hospitalization, right? So hospitalizations improved even if the primary outcome did not with candesartan. And then move on to TopCat a number of years later. So the inclusion EF for this group was 45%, similar outcome, again, a similar primary outcome and a similar non-significant results. However, in a story that I think is now pretty well recognized, is that there was a significant geographic difference here in the patients who were included. So almost half the patients were from either Russia or Georgia, and the rest were from the Americans. And it's now regarded that, and I'll talk about this more in a minute, but most of those patients from Russia and Georgia probably did not have HFpEF. And so confounded or contaminated the study. And if you just look at the ones from the Americas, this was actually a positive study. Spironolactone actually benefited those patients. So again, it's kind of tantalizing, and maybe spironolactone really does work, but we can't recommend it in guidelines based on this, right? And then Paragon. Okay, so Paragon, again, looking at sacubitril/valsartan, EF of 45% or more, same primary outcome, same result from the trial, although, boy, we got close on this one, right? 0.06 was the p-value, okay? And I forget the exact number, but I think the number of extra events needed in the placebo arm was like single digits to make this a positive trial. And that must have been just heartbreaking for Dr. Solomon and the rest of the steering committee to come so close, but not quite there, and not enough to enter guidelines. And so yet another negative trial, but more food for thought. And that brings us to Emperor Preserved. So Emperor Preserved just came out this year, and it included patients with an EF of greater than 40%. Looking at empagliflozin, an SGLT2 inhibitor, which are now all the rage in heart failure, patients with or without diabetes. And hooray, it was a positive study, right? So hallelujah, we finally got there. This has not yet been incorporated into guidelines because it's so new, but it was driven again by heart failure hospitalizations. That was the driving benefit for that primary outcome, was heart failure hospitalizations. But I think we're all going to be jumping on the EMPA bandwagon for HFpEF if we haven't already, because we've got a positive trial. So that's the big news. So that's kind of the punchline for the talk. Okay, now I'm going to take a step back here and just take a broader lens look at heart failure, and particularly with HFpEF, okay, and just see how that colors our treatment and our perceptions of this disease, this disorder. So the Heart Failure Society of America, along with a few other heart failure societies, including the Canadian one, came out with new criteria for really defining and categorizing heart failure. And, older definitions of heart failure, I mean, this is similar, it just kind of frames it in a new light. Older definitions would say, it's a complex clinical syndrome that is based upon structural or functional changes in one or two of the ventricles, causing kind of a classic symptom constellation at rest, or with exertion, another way of saying impaired reserve, right? So they kind of rearranged that, and so here's their definition of heart failure: signs and symptoms caused by structural or functional cardiac abnormalities, corroborated by at least one of the following: elevated natriuretic peptides, reflecting our current practices and how we diagnose heart failure, and evidence of cardiogenic pulmonary edema or systemic congestion. And they list a number of different criteria and categories and ways of dividing up heart failure. And this is one of them here that you see on the right: stages of heart failure. This has been around for a little while. I've never really used this. I don't know anyone that really does, to be honest, but it's been in the literature for quite some time. What we all end up coming back to is this, right? The EF categories. And why do we keep coming back to this? Why is this so important? Well, this is, again, what guides our therapy. This is what determines how we treat patients based on clinical trial data. This is driven by clinical trial data, really. Okay. Now, the new criteria have these 4 categories: HFrEF, HFmrEF, or HF heart failure with mildly reduced, used to be mid-range, now it's called mildly reduced ejection fraction; HFpEF with an EF of greater than 50%, and then HFmpEF, which is patients who have had improved ejection fraction after being on treatment. I don't really love this, I'll be honest. I'm going to kind of shoot from the hip here for a sec. I've never been a fan of having the 3 categories that they had before, never mind now having a 4th one. I think it complicates things, and it represents a bit of a disconnect, to be honest. Well-intentioned and trying to reflect the nuances of treatment response, bit of a disconnect between what's in the guidelines and what we actually have to do when we're looking at patients. And why do I say that? Well, it's hard enough to have 2 categories, one that has 12 different drugs, and one that has none, or now 1. But then you add this middle category of HFmrEF, where maybe some work, maybe some don't, really hard to know. And then you add HFmpEF, and it's just, okay, just keep your head down and keep doing what you're doing, right? I find this is more difficult, and I'll show you a bit more evidence as to why I'm against this. This is purely my bias, but I'll try to explain that a little bit further. And so, this clinical trial data kind of created this disease in a way of HFpEF. And when we talk about its pathophysiology, sure, we notice differences with HFrEF, but HFrEF has kind of similar complex, multi-pronged spoken wheel with lots of things going on, and very hard to know which one of them are causes and which one of them are consequences of the disease, and does this, again, also really, this construct really help us much in clinical practice? I think it illustrates the point of how much we don't know about the disease rather than how much we do. But certainly over time, we've come to recognize very, clinical characteristics of patients who we diagnose with HFpEF based on their phenotype, or, their kind of non-echo, or not necessarily non-echo, but more clinical criteria, okay? And what does the typical HFpEF patient kind of look like? So here on the left is a phenotype-based diagnostic algorithm. It's gotten a lot of traction in the literature. Again, I don't use it. I don't know others that use it regularly, but I'm certain I could be very wrong about that. But it makes sense. It includes things like HF2PEF, or HFpEF, which is patients who are heavier, have a high body mass index, or are hypertensive, patients with AFib, pulmonary hypertension, patients who are elderly, patients with high filling rate based on their echo. And it has a nomogram and scores, and you can try to assess their likelihood of having. So like I said, this is popular in the literature, and it gets referenced a lot. more recently, the European Society of Cardiology came up with this. This is a diagnostic algorithm for HFpEF, more complicated. It occurs in stages, so looking at different kind of phases of the workup to assess the likelihood, and then at the bottom incorporating different phenotypical categories, functional, morphological, biomarkers. So more complicated, but endorsed and come up with by the European Society of Cardiology, right? This isn't, Fine and Sharma coming up with this. This is the ESC. So which is right? Should we use one versus the other? Well, I don't really know. Here, these authors looked at both of these scores using the TopCat cohort, patients in the TopCat study, and compared them and found that they really didn't agree with each other very well at all. So there was a small area of overlap for patients who were at high risk for HFpEF, but almost a third, 28%, had discordant scores. They were high risk by one and high risk by the other. And these are patients who were kind of initially screened for having unexplained dyspnea. So I don't know. I don't know what the truth is. Maybe it's one, maybe it's the other, maybe it's somewhere in between. Okay, again, illustrating the challenges of this disease. But further to that thought, and trying to not just type, but group patients. So we're looking at an overall type, that's a phenotype of patients with HFpEF, but then looking at subgroups of patients who have HFpEF. This was just published last year, again using the TopCat criteria, and they came up with 3 different pheno groups. Okay, and this resonates a little bit better, I think, in some ways. Now, this first group, these were essentially the patients from Russia or Georgia, and they had kind of normal this, mild that. A lot of these patients had hypertension, a lot of them had coronary artery disease, a lot of them were smokers, which we think is why they were short of breath, but likely these patients did not have PEF. But the other two, kind of patients who are older, perhaps frail, who have very stiff arteries, very high afterload, they had, they were included. And then the highest risk group was patients who kind of had the metabolic syndrome, who were overweight, more likely to be diabetic, kind of very metabolically active. And interestingly, when they broke it down, these patients not only had the highest risk, but they also had the best response to spironolactone. So maybe something like this could be used to guide our treatment a little better and refine things, maybe. But then you look at something like this, which is a very similar study using fancy statistical analyses to subgroup patients with HFpEF from the TopCat study. Okay, same group of patients using, all of the usual suspects, BMI and NYJ class and hemoglobin, etc. They came up with 3 groups, but 3 very different groups that were really just based on severity of disease. Okay, groups 1, 2, and 3. And again, no surprise, group 1 had the best response, okay, to spironolactone. So maybe we should use this to phenogroup patients with HFpEF, right? I don't know. Because we've got a whole bunch of other studies using fancy statistical analyses doing the same thing and coming up with different categories. Some of them have 3 categories, some of them have 6 categories. Okay, and where, what do we do, and where does the truth lie, and how does this help us really in clinical practice? We're still figuring that out. So just one more thing I want to touch on here, which is the treatment response of these HFpEF trials based on ejection fraction. Okay, so we know, we see this in HFrEF too, that the lower the ejection fraction, the better their response to treatment. So we saw this in Emperor Preserved, right? Patients with the lowest ejection fraction, and remember, entrance criteria for this was EF of 40% or more. Those patients did the best. They had the best response to empagliflozin. We saw something similar in Emperor Reduced. Okay. What about Paragon? Yeah, patients with the lower EF had a better response to sacubitril valsartan than the patients with the higher EF who also had HFpEF. And what about TopCat again? Same thing. Patients who had the lowest EF had the worst outcome. Okay, patients who had the lowest EF had the best response to spironolactone. Okay, so there's a trend here, right? And so maybe we're looking at this the wrong way. Maybe we need to look at this as one disease spectrum when it comes to EF and treatment response, and how we use the therapies that we have available to us rather than kind of lumping them into categories. Now, how best do we do that? That's for someone smarter than me to know, but I'm a simple guy, and that's why I say, this is maybe not working out so well, and maybe 50% is the cutoff we should use for treatments, because clearly these HFpEF studies have shown that patients who have an EF of 40 to 50 benefit more from these therapies. Okay, so just to summarize, HFpEF remains a challenging disease to diagnose, even more challenging to manage. The big news, empagliflozin demonstrated a positive outcome in patients with HFpEF, so we now have a drug to use to treat this. In general, HFpEF trials, both those who are positive and those that are not, have demonstrated that when there's a benefit, it primarily reduces hospitalization, okay, as opposed to improving lifespan. And then there's a spectrum of response demonstrated by a patient's EF. There have been modern efforts to phenotype and phenogroup HFpEF to aid in diagnosis, but really a unifying HFpEF algorithm that helps us diagnose and manage this disease, I feel, is still lacking and is an important gap in patient care. So that's all I got, and I hope that was interesting and helpful. Thanks very much for listening.
Yes, thank you, Noel. And I actually have a couple of questions for you. I don't see any in the chat, but I have some questions for you. So as we look at the management of HFpEF, and as you imagine how you think you should treat a patient, let's not talk about phenotypes. If you're going to decide, after you decongest the patient, what is your first line therapy? Is it now going to be an SGLT2? And then the corollary to that question is, do you believe the reduction in the heart failure hospitalization is sufficient enough that as second line, unless you think it's first line, you're going to use an ARB, you're going to use an MRA, or you're going to use Entresto? So how do you decide which agent you're going to use first, second, third? Let's put cost aside, because we know cost and coverage will be an issue for a short time until we get that figured out. But let's say you didn't have cost and coverage as an issue.
Yeah, great question. Tough question. I would definitely use empagliflozin. I think the trial is very convincing. And I would, use it universally for patients who I believe have HFpEF. Of interest, there's other SGLT2 inhibitors out there. They're not being investigated at this moment in the same, they're being investigated for HFpEF, but not kind of a trial the magnitude of Emperor Preserved. I expect that will now be coming. I think that patients who have hypertension would benefit from sacubitril valsartan. I think spironolactone is a very easy drug to use, and I believe that it can be benefit to these patients across the board if we're forgetting about phenotyping. So I would use all three. Now there's renal function caveats, there's potassium caveats, right? But I think we need to kind of look at those study results, with our clinical eyes on as opposed to our statistical eyes on and say, does it make sense? I think it does. But I think I would definitely use empagliflozin first.
And do you have any comments about the FDA's approach to what they decided with Entresto? Because they approved it for HFpEF, right? Whereas the Canadian groups have not. So what's your take on that?
Yeah, I don't know the details of that so well, and kind of the FDA, the process the FDA went through. Others, Jonathan might know more. I think it's very forward thinking to recognize that we've got a very significant disease that we don't have treatments for, and to use a very kind of small, if the trial had gone on for a few more months, it might have been positive. So I think that's very progressive. I would love it if Health Canada took that approach. I'm not going to hold my breath on that. Otherwise, I might start to look like some HFpEF patients. But those are my kind of from the hip thoughts.
And I guess my only last comment would be, I think Deliver, I don't know how big Deliver will be with dapagliflozin. I think it is going to be a pretty reasonably big trial for HFpEF, right? So
Deliver?
deliver, correct?
I could be, yeah, I know what, if I misspoke and deliver is a bigger trial than I thought, then.
Yeah, I don't remember what the size is. Jonathan, do you remember what the size of deliver will be? No, okay.
I think it's 5,800 people in the trial. It's going to be a big trial, yeah.
It's going to be a pretty big trial.
Okay, so I misspoke. Thanks for.
Yeah, I thought there was that one trial.
Yeah, I'll get you the paper for it, but it's a very large trial.
Okay.
4,700 or 5,700, I can't remember.
And I think that one is supposed to be probably closing up at the end of this year and potentially being presented next year at ACC, if I recall correctly. So thanks very much, Noel. I don't see any other questions in the chat. Please feel free, guys, to either type them in, or if you want to ask questions directly, feel free to do that. We're going to move on and talk about the rebooting of the cluster approach and with Dr. Miller. So Rob, take it away.
Thanks, Sandeep. I'm sort of struggling with internet connection issues here, so hopefully it's gonna proceed okay. These are my disclosures. So as we all know, there's sort of the 4 big drugs on the block for patients with heart failure with reduced ejection fraction now. And this is the big change in the last couple of years in heart failure, where we have 4 agents that really seem to have benefits across the full spectrum of patients with HFrEF. And that's ARNI, MRA, beta blocker, and now the SGLT2 inhibitors. And importantly for this, it seems that the benefit from each of the drugs is additive, and there's no specific synergistic relationships, by which I mean it's not that being on an MRA seems to improve your benefit from beta blocker or detract from your benefit from beta blocker, and that seems to be the case across all of the agents. So this was a network meta-analysis performed by Kamashta et al. So with a network meta-analysis, what you do is you use data across several different trials to try to come up with comparisons that weren't necessarily present in one of the trials. And what this shows is with increasing therapy, so with ARNI, beta blocker, and MRA versus placebo, you get a very strong reduction in all-cause mortality. So this network meta-analysis was done before the SGLT inhibitor trials were available. But since then, Milton Packer presented an analysis of Emperor reduced, where he demonstrated that there was really no impact on the benefit from SGLT inhibitors from ARNI. So presumably the benefit there is additive as well. In our review paper, we looked at this a slightly different way and said, what if you take an average 6-year-old guy with ischemic cardiomyopathy and you just decide how many agents you're going to treat him with? And what we showed here is that with foundational therapies, which is ARNI plus beta blocker plus MRA plus SGLT inhibitor, you can decrease 1-year mortality from 17% to 4.7%. with potentially more benefit by adding ibabradine in patients that would qualify and demonstrate mortality benefit. Yet another way to grab this. So this is by Duganathan et al. In Lancet, and really helps drive the point home. So what they did here was compared conventional therapy, just an ACE or ARB plus beta blocker, compared to comprehensive therapy, which is ARNI plus beta blocker plus MRA plus SGLT inhibitor, and looked at what is the increase in median survival. So for an average 55-year-old patient, if you get them on comprehensive therapy, it's an extra 8.3 years of life. And for an average 65-year-old person, it drops up to 6.3 years of life, but really very significant and powerful benefits from getting all of these therapies on together. So that really forms the core of what we're thinking about now with heart failure therapies, where it's critical to get all of these drugs on board and titrated as quickly as possible. So how good are we at doing that? The short answer is not very good. The longer answer is, and this is why. So this is work from Stephen Green. So he looked at 2,588 stable patients with HFrEF in the CHAMP registry. And what they looked at here was increase in medical therapy over time. So all the bars that are gray mean that patients aren't receiving those therapies. Orange means they're receiving less than 50% of the goal dose. Yellow is greater than 50%, and green is at goal dose. So the important thing there is that really rates don't change over time. So you see a little bit of a drop off in terms of ACE inhibitor therapy and small increase in ARNI therapy over time, but in general, patients weren't being titrated on these medications. This is a study that looked at it a slightly different way. So this looked at pooled data for patients who were admitted for heart failure who hadn't previously been on medical therapy. And I think it highlights a couple important things. One, clearly there are differences in how long people write their prescriptions for. So in Sweden, they write them for 3 months at a time. US, they write them for a month at a time. And you can see immediately after hospitalization, patients mostly fill their prescriptions, but very quickly start dropping off when their first refill would be due. That's patients aren't being seen in follow-up, and maybe things like heart function clinic and the clinic that May is helping to run with the early continuity clinic and help improve this, just making sure patients aren't falling through the crack. The other thing it highlights is that in general, over time, there's a slow reduction in treatment. So red here is treatment that's discontinued. White is sort of low dose, light green is intermediate dose, and dark green is on target dose. So very few patients are titrated to target dose. Many patients are having their therapies discontinued, and there's a huge gap after discharge where patients will fill their first prescription, but if they don't ever come back to see physicians again, it's just discontinued, and that's a lost opportunity to start therapies. So although it's relatively simple, we're still not doing a great job of getting people on therapies. And maybe it's partially because it's not really that simple. There's lots of other things that you could consider. So you could think about iron replacement. If patients are having cost concerns, you may be thinking about ACE inhibitors. Certain groups seem to benefit more from hydralazine and nitrates. There's mitral clip, anticoagulation, DIG, and pulmonary vein isolation now for patients with AFib, CRT, ibabardine, the list goes on. And it seems like every couple of months there's going to be something that could be added to this list to still think about, which makes heart failure exciting, but also a little bit more complicated than it needs to be. So the guidelines really tried to make this simple and really make it abundantly clear where the benefit is. And that's all patients should be initiated on these standard therapies. If either ARNI or ACE/ARB, then substitute to ARNI, beta blocker, MRA, and SGLT2 inhibitors. And then afterwards, you can start thinking about things that you might consider as sort of personalized therapies, or however you want to phrase it. In terms of how to get there, though, not great evidence initiation strategies, but you should initiate standard therapies as soon as possible, titrate every 2 to 4 weeks to target maximally tolerated dose by 3 to 6 months. And as we saw in the previous graphs, really the thing is you have to keep working at it and not just leave patients either off therapies or on low doses of therapies. So if you were going to take this guideline said to the extreme and try to make it so that you change one agent at a time, make it change every week, and try to get people on therapy, you can just make it in the 3 months timeline. With this strategy that I sometimes use in cardio-oncology. My pet name for this is the titration strategy that drives the nurse insane. And that's because it's a change happening every week. It's a different change every week. It's hard for patients to follow. But if you have a really good pharmacist and good nursing support, this is something that you can think about in patients who are more frail. And it will get you to target doses of everything by 3 months, but it takes a lot of work. And if you fall apart anywhere along this titration plan, then get out your pen, because you're probably going to rewrite out a new titration. So this is from Milton Packer, and he sort of put together a hybrid of what you proposed with the cluster scheme and compared it to the conventional sequence. So like we said, conventional sequencing, you start a drug, you start the next one, you slowly titrate over time. It typically takes months or more to get there. He was suggesting everybody start with the beta blocker and SGLT2 inhibitor up front as the first drug, and then alternate ARNI and MRA in terms of where you start it, and then titrate drugs with the goal of getting everything titrated within 3 months, up